Welcome to case presentations. So I'm going to start off first with my case, and essentially this is an 83-year-old gentleman, history of paroxysmal AFib, prior DVT, hypertension, prior CVA, stroke as well. He presented after developing slurred speech, left facial droop, left-sided weakness. CT showed a right MCA stroke, and he was actually given IV TPA. And he underwent neuro-IR clot extraction from the right M1 distribution with restoration of blood flow. His examination, non-fluent, severe dysarthria, and strength in his left upper and left lower extremities was 0 out of 5. Cardiac examination was regular rate and rhythm, no murmurs, rubs, gallops, and a enlarged PMI. So here's his EKG, just to take a look at for consideration when we take a look at his imaging. Anybody notice or anybody want to call out anything in particular in regards to this EKG? Just the one striking feature that's noticeable. Wahash. Well, he it is hard to see the P waves here just because of basically the voltages here, right? But just some low voltages on this EKG. Here's his chest X-ray, a little bit of pulmonary edema, but otherwise moving on to his labs. His labs were significant for an elevated BNP of 2,421. Troponin was negative. So we've got his echoes here. Oops. Okay. So, anybody want to take a crack at the images? Not the best quality. Yep. Ahmed. Sorry, I caught you with some food.
Top left is first row image. First row image. The looks a bit mildly depressed. The angulation, I don't know if it's just the way the image is, or but the angulation between the aortic valve and the mitral valve looks a bit tight. The mitral valve deeper looks like it's moving okay. The aortic valve looks like it's moving okay. The right lower LV looks like it's thickened. I mean, there's moderate at least LV thickness, 15, 16 millimeters.
Yeah. So I think you've hit some good points here. So it looks like the LV does look a little bit thick. There is a mild depression in the LVEF as well. Here's some more images, and essentially we see a tall E wave, almost non-existent A, and then we have our tissue Doppler at the lateral as well as the medial mitral annulus.
Looks like it's dilated. Mitral valve looks like it's okay. Right atrium is probably dilated. Just right on the top right, the subcostal view.
So I will tell you that there was a call about a potential linear echo density in the right atrium here on the echo, which prompted the team down in the ICU to further image with a cardiac MRI. But I think overall, you got a lot of the important points. Some diastolic impairment, thick LV, mildly depressed EF, enlarged LA, and then, yeah, and the EKG, exactly. So all of that going together. Yeah. So here's the cardiac MRI. I've got a couple of images extracted. You guys can let me know if you want the full study. So here are a couple of the images to evaluate for late gadolinium enhancement. For this, I will ask Dr. Eric Yang to help me out here. Yeah, so calling this, some subendocardial enhancement right over here. And then also you can see the subendocardial enhancement in these images, and then you see some enhancement of the interatrial septum, which is all highly suggestive of some kind of infiltrative or amyloid type picture. So on this image, you know, some on this four chamber, so enlarged atria, biatrial enlargement, and then some thickness of the LV as well as thickness of the RV as well. So his labs were unremarkable kappa lambda ratio and largely unremarkable serum protein electrophoresis. So knowing that, what further imaging would you use? Would you go for biopsy? What kind of management, if everything here is indicative of an amyloidosis of some type, what would you further investigate with? So I didn't notice it. Yeah, it's definitely thickened here. So it's definitely thicker, but on the late gadolinium images, I just noticed the subendocardial of the LV. Biopsy, pyrophosphate. Okay. All right, so we went with the pyrophosphate exam. So basically, cardiac amyloidosis. So TTR amyloidosis is a very underappreciated cause of heart failure. This can actually be seen in our HFpEF population, in that wild-type TTR amyloidosis is found in autopsy in over 30% of patients with HFpEF that are greater than or equal to 75 years of age. You have the different types of amyloidosis. You have AL amyloidosis, which are IgG light chains produced by clonal proliferation of plasma cells. And you have ATTR amyloidosis, which are misfolded monomers or dimers of a normally tetrameric TTR protein. It can either be a mutant, ATTR-M, or familial amyloid cardiomyopathy, or wild type. And the treatment is vastly different between the two. AL amyloidosis would involve chemotherapeutic agents and treatment of that, whereas ATTR is produced in the liver. So the gold standard is endomyocardial biopsy. but it behooves us to have an imaging modality that would be able to differentiate between AL versus ATTR subtypes of amyloidosis, and that is the Technetium pyrophosphate scan. So it's a bone tracer. It has affinity for calcium-containing compounds, and it's hypothesized that the affinity for amyloidosis is related to increased concentration of myocardial calcium in patients with TTR and TTR-related amyloidosis. And this was actually used in the past to image scar, myocardial scar as well. So we have a study here in 2013, Bokhari et al. I believe Dr. Mamarian showed this last week, but this had several patients that were biopsy proven and grouped into AL amyloidosis versus ATTR, and they performed the pyrophosphate scan on them. And basically what you have here, you have a visual scoring of cardiac retention. So here, so 0 is absence of cardiac uptake, 1 is mild uptake, less than bone, moderate 2 is moderate uptake, equal to bone, and 3 is higher uptake, greater than bone. So essentially what you do is you create a region of interest here at the cardiac region of interest, and then a region of interest on the contralateral side, and that's to control for the amount of uptake by the bones of the ribs. And here we have a negative uptake scan example, and they have the counts here, and then they have a positive uptake scan where you see uptake by the heart and positive uptake compared to the contralateral side. And so heart to contralateral ratio, they find that in their study they were able to differentiate by a value of 1.5. So the heart to contralateral ratio of greater than 1.5 lended to the diagnosis of ATTR amyloidosis versus less than 1.5 was suggestive to AL amyloidosis. There was an outlier here that had an unusual mutation. So this is our patient that underwent the pyrophosphate scan, and you see the uptake over the heart and compared to the contralateral side. And I believe his ended up being 1.55. So in his case, with the low voltages, the thickened LV, the restrictive cardiomyopathy, the subendocardial late gadolinium enhancement, as well as the results of the pyrophosphate scan, all of these multi-modality images were suggestive of the diagnosis of TTR amyloidosis in his case. So eventually, during his hospitalization, unfortunately developed worsened complications, respiratory distress, hypoxia, PEA arrest, critical on multiple pressors, and unfortunately the patient passed away. That's it.
Moving now from myocardial disease to valvular disease, and this was a kind of an interesting case we came across. So he's a 71-year-old gentleman who has had a bicuspid aortic valve and underwent a St. Jude mechanical AVR 2009. Of note, this was his second valve replacement. His previous one was, I believe, in 2005. Seen in clinic for progressive dyspnea, New York Heart Class 3, has had an outside hospital echo, transthoracic, and then he was referred to us for a transesophageal echo. So kind of we're going to this long axis view on TEE, and I'm going to play those loops, and then we're trying to get a sense from one of the fellows in terms of what is going on with this mechanical AVR. So that's one view. This is here on an X-plane. And then this is kind of in a modified short axis view at a higher degree, almost at 70 degrees angle. There were some 3D obtained on the valve itself. And this was a short axis of the aortic valve on 2D and 3D. So, any volunteers in terms of what is going on with this bileaflet disc, and what do you think the mechanism of this regurgitant jet we're seeing? Bashar?
So I just walked in.
You just came in, okay.
I mean, it looks like, I mean, obviously, the AI is significant. The etiology of it, on the short axis views, I was going to say perivalvular, but on one of the short axis views, it looks like it's the one with the 3D. Or
Yeah.
right before the 3D.
Yeah, the 3D seems central.
Like that one makes me think there's some, either the leaflet's restricted and it's just not closing all the way. Because that looks within the valve frame.
So that's one possibility. You're saying a possible transvalvular aortic regurgitation in the setting off.
Like a restricted leaflet that
disc.
can't close or.
Good, I'd
collapse
like
all the
to
way.
see a little more 2D or 3D alone without, once you see an abnormality, right, and try to define abnormality by color, you'd like to really explore the whole opening and closing mechanism. See,
So-
the problem you have with the one on the left side
Mhm.
is all what you see is the tip of those leaflets when they open.
Sure.
You see what I mean? So I don't have a feel for the crux of the valve itself. So
Yeah.
another shot would be a little lower
Yeah.
so that you could see them in systole and in diastole. Here you see them only at the tip of systole
Sure.
when the leaflets are open.
Yeah.
Because this 3D view, we're looking from the LVOT out here?
Yeah.
or-
From the LVOT out, correct.
And here you get a sense that maybe that, I guess the anterior leaflet is not fully closing. but-
No, that was just, I think it just
Maybe
had
that
to do
just
with
kept
the
dropping
cropping.
in and
Every
out.
time we cropped it
Yeah.
down,
Yeah.
it just looked like it was sticking.
Yeah, I mean, to be honest with you, it was there
Very
was a
hard.
sense of the eccentricity of the jet
Yeah.
that think that it looks possibly paravalvular, but really on 2D, it's really you cannot tell for sure whether it's valvular or transvalvular.
The direction tells you most
Yeah.
likely it's paravalvular,
Sure.
although on one shot, actually, coming up, you were, I can't exclude a component of valvular.
Absolutely, yeah.
But whenever you have an eccentric jet like this, coming from one of the corners and cutting almost perpendicular to the alveolar tract,
Sure.
you can almost take it to the bank, that it is something paravalvular.
So I'm going to walk you with what exactly was the interpretation of this study was. So what they thought was it was a severe eccentric posteriorly directed aortic regurgitation, so they thought it was valvular. And then the mechanism appears to be due to a restricted mobility of one of the leaflets.
Is the last part of the statement correct?
Not according to, so here's the deal. I think there was some confusion with the 3D pictures, like you only can see one disc, you cannot see the other one. And then you, as you said, you see the opening, but you don't really see the closure. So based on this here alone.
My advice for you
May or may not be.
is whenever you see something anyway, you need a good 2D TE,
Yeah.
not a biplane, not an X-plane. And the problem with an X-plane is it drops your frequency. It drops your frame rate. So
Absolutely.
don't abuse it. You know, use it at times for trying to get orthogonal views,
Sure.
etc. But you gotta go all the way down to see whether you open and close and everything else. 3D in an aortic valve is an issue. You know, this is among the better views, believe it or not. Most of the others are not good. And our experience is less than 20%, where less than 20%, where you could see the mechanism and say your last statement that this thing is either opening or closing well. I cannot tell,
Yeah.
right?
So the question was, where do you go from here? What would be the next imaging modality that helps kind of segregate what we're seeing? So CT was brought up. The referring provider decided to do a cine fluoroscopy to look at the mechanical valve,
Yes.
which I mean they're both kind of considered appropriate by the guidelines.
What's the difference between, why would you do one versus another? I mean, it's important for us, this is, why would
If
you?
you think it's a primary restricted leaflet, then I would do a fluoroscopy. If you're
And
concerned about paravalvular, then you're not gonna get any discernible information with the fluoroscopy.
Hmm. What's another advantage conceivably of a CT?
You can figure out the etiology why there is a restricted, or, you know, you can differentiate between a thrombus, a pannus. You can also look for other causes like an infection.
Conceivably, yeah. So if you're interested in the mobility, whether the angulations are correct, yes, no, fluoroscopy is very easy. People don't do it as much, but I'm surprised and nicely surprised that fluoroscopy has been done here.
Yeah.
And I mean, another message for you is, don't stretch it. Don't
We
stretch.
really stretched it.
Don't stretch what you see. And let me tell you, every time I talk about prosthetic valves, we have limitations in echo on aortic prosthetic mechanical valves by TE. So don't tell me, I mean, unless you're really confident, then these valves open and close well, and say, I cannot assess the mobility. So somebody else knows what to do. If you tell them hanky-dory, you know, they're gonna take it as a gospel and run with it. So just know the limitations and spell them out. It doesn't make you any lesser interpreter nor lesser sonographer. Actually, it makes you better.
So I selected probably the 4 best shots. The others were unfortunately outside the field of view. So Nishant, what do you think about the discs opening and closing here?
So here again, we are only seeing the one leaflet
Yeah.
is moving by the same time
Mm-hmm.
for the fluoroscopy to, so I cannot definitely say
Can
that
you
it's
run
here.
one at a time before we get dizzy?
Yeah, absolutely.
It's moving so much, it's like,
No, you start a pan as well at the same time.
yeah, it's like,
Yeah. Bad for me. Actually, you could stop one, you understand, from
you
your
can do one
quad.
at a time.
Oh, just stop it? Okay.
Yeah, you understand, then you can run whichever way they want.
Yeah, I got you, okay. So we'll do one at a time.
There you go.
Alan
Okay,
didn't even see anything.
the echo, not the echo, the fellows. Okay, the fellows who have been in the cath lab or have not been in the cath, could you criticize the first one?
Yeah, you can't say anything because you don't know, you can't see the leaflets. And then you're kind of foreshortening, or for whatever reason, the other leaflet
And it's behind the sternum.
seems that it doesn't exist, which I will tell you that we kind of biased ourselves by looking at this, and we convinced ourselves that the leaflet was moving.
Okay, to tell you the truth, this patient has had 1, 2, 3, 4 fluoro runs.
And none of them
1, 2, 3, 4 fluoro runs. They were all bad because the person who's doing it has no earthly idea how to evaluate the prosthetic valve. No earthly idea. How do you evaluate a prosthetic valve motion on fluoroscopy?
You'd want to be on FOS, so one shot ideally up and down.
En face meaning, if this is the
Well, I'm
edge
saying
of
if you're
this-
gonna
Like
get two
that.
views,
You
one
should
like
be
that,
able
and
to
then
see the
one
tilt.
at the hinge. So you see the valves.
You want to look down the gun barrel of the
Yeah.
hinge point.
Yeah, the hinge
Yeah.
point.
With the valve flat,
So you should
Yeah.
see the,
parallel with the annulus.
So that your view has to be not like this. You're gonna have to see the ring.
Yeah.
And the reason for it is the leaflets are up and they're gonna be in your direction. So that, number one, you adjust your fluoro so that the ring looks like a line. Okay, that's one. Two, you start rotating the tube till you see them, see the leaflets like this. That's the only time you're going to be able to see them well. You see what I mean? Otherwise, you're going to emphasize one versus another. And then once you see them like this, and this is the annulus, you see them like this, then you see whether they're closing and opening correctly. One of them could be stuck, the other one could be moving, or both of them could be moving but restricted, meaning there are published angulations as to what the angle should be when they open up. So this person had 3. Let me tell you, if you see this en face like this, I'm not sure what you're going to be able to see.
You're
because
only
the
off by
leaf-
90 degrees.
I mean, you would be able to see something.
No,
But it
then
wouldn't be.
You think
you
that
won't
you
be
have a
able-
ring.
It'll be worse than your echocardiogram.
Those are all shots of the ring. Nobody cares about the ring. You know the ring is there.
Yeah.
Yeah.
They're just telling you there's a ring.
Then you'll pass the wire through it like I did.
No, but it's very interesting because this person went through the trouble, got some radiation. I mean, we're here to learn,
Yeah.
right? We're here to learn, but I would have thought that somebody in the cath lab would know how to image it. And if they don't, ask around. I'm not sure, I'm not kidding you. You can even Google this stuff. And a YouTube video, a YouTube video will, just like you're fixing something at home, will guide you.
So since this was a real-time case, we all agree that the windows and the angulation unfortunately was not adequate, but the findings per the report was one of the leaflets appeared thickened and restricted in motion, suspect due to palace growth. So next,
Oh, wow.
was, as you all voted for, was a cardiac.
Multiple leaps of.
No, but I mean, I could not see, I mean, can you show me the abnormality that somebody has seen?
Yeah, to be honest with you, I think
Okay.
we all
I
agree
imagine.
that it's not adequate to kind of assess the
Yeah, right.
valve. So patient did undergo a CT, and for those who are concerned whether the valve is opening or closing or whether there's sinus,
Beautiful.
it's beautifully en face view, and there's nothing wrong with the valve itself. And then, interestingly enough, if we focus here basically on this 3-chamber view, right next to this area here, we do see a small paravalvular dehiscence where the pointer is, and this is basically kind of crossing in a multiplanar reformat, and we basically lined it up right across through this defect, and we see this little circular, more like an oblong shaped paravalvular leak, and that's basically where the aortic regurgitation was coming from. I think I have more zoomed views. There was actually, this is here a little bit more zoomed. There is some streak artifact from that mechanical valve, but on the short active view, and lastly, you can see some tissue separation. Right, this is the RVOT here, and this is here, it's going to be the little valve dehiscence. This is the right atrium here, this is the left atrium, and the pulmonary veins.
Okay,
And
questions
this
to
is
you.
basically was another small defect right next to the origin of the right coronary artery. So kind of roughly, it was like anywhere from like 15 to 20% of the annular area was the size of the defect.
Muhammad, why couldn't you see this on transesophageal?
Well, I mean, I think we're probably below where the, I mean, we never nailed down where the origin of the AI jet is. We were just seeing basically all the jet area kind of striking out all through the LVOT. So I guess it was just difficult because of all the acoustic shadowing to kind of go high up into, it's almost like close to the non-coronary cusp is where that PVL was.
There are two reasons,
That's
right?
probably
And
because
remember,
one
an
is
echo is very important. There are 2 reasons. One, this was transesophageal.
Yeah.
Okay? Transesophageal is great for posterior as
Posterior
opposed to
structures.
anterior,
Yeah.
right? Because then you'll have shadowing from the prosthesis itself in the anterior distribution. And we've written on this many years ago that for you to address prosthetic valves, you have to use a combination of transthoracic and transesophageal, because the transthoracic is good for the anterior structures, TE is good for the posterior structures, trying to nail it down.
Exactly, yeah.
And the other one is, how do you conduct your transesophageal? You see what I mean? We saw a lot of shots in the LV outflow tract.
Yeah.
You didn't see as many shots at the ring itself, where the origin of the regurgitation is.
Sure.
You see what I mean? So these are the things. And at times you could do it in the TE room. You're done with that. I just want to see anteriorly what it looks like, and you merge it. It's not a, you get a full study.
Absolutely. So I guess now that we know what the problem was, it was decided that the patient, after it was discussed in the valve conference, that for a third redo would be risky. And then there was a successful attempt to put in an Amplatzer PDA occluder device was just done yesterday. So these are nicely what Punraj actually did was he co-registered the CT that the patient had. So this is the one defect here, and this is the other defect right next to it. And these are these little circles are the origins of the coronary arteries. We can nicely see here the guide wire going down through that defect here on real-time TEE. And this was kind of the zoomed view with the guide wire in. This is where the defect is.
Nice.
So it was very it was very, it helped. The CT basically did guide the procedural intervention. And this one here is after the Amplatzer was deployed. And this is how it looks. It's a kind of a second generation PDA occluder. And then basically post-procedural, there was only mild
That's physiologic, actually.
regurgitation. Yeah, I think there was another shot, probably.
Now,
showed
the
some,
question to you, Steve, is if the defect appeared to be almost in the, not at the hinge points,
Yeah, it wasn't.
and if it was closer to the hinge points, would you still go with with a occluder device? You'd get concerned about maybe getting into the opening and closing.
So there was a lot of discussion around the type of device to be used, because some devices like this one have, it looks cylindrical when it's not constrained in any way, but in fact, when it's constrained between tissues, it takes on more of a mushroom shape. So the cap gets a little rounder, the waist is a little rounder. We talked about a DSD occluder, ASD occluder, PDA occluder, different types, and ultimately we went with this one because the dimensions, I think, were by CT 3.5 or 4 millimeters wide by about 10 millimeters long. It's a big crescent-shaped defect. So that's some of the concern. I mean, it's this oval defect, and you don't quite know where the device is going to land. If it lands at one extreme, it would have been actually quite close to the hinge points. If it lands at the other extreme, it's far away from the hinge points. And it sort of centers itself a little bit in the middle. So that's partly why echo's there, is you inflate the device, it's still attached. You do a full evaluation of the function, make sure the leaflets are moving properly, and you sort of do that overview before you let the device go.
So I guess just take-home messages from this case really was difficult based off the TE alone to delineate whether this was a valvular or a paravalvular. The eccentric nature of the jet probably was supportive of a paravalvular leak. The cinefluoroscopy angles, unfortunately, were not adequate on this case to do a proper valve assessment. And final message, CT was king, and I repeat, CT was king, utilizing the PVL and sizing the defect along with assessing the valve morphology and function, and also did a great job guiding intra-procedural.
But I have to add that Ponraj was Prince then. Because it was very helpful, actually, because there was
Exactly.
a co-registration
You're
of
right.
2D images of the pre-procedural CT onto the fluoro shots. And we didn't do any cone beam CT or anything in the room. It was just
Yeah.
CT to fluoro. And he put these markers on, and Colin was very, basically it was a bullseye, catheter bullseye based on the CT.
Very nice.
Yeah, no, it was a nice case.
Okay.
Thank you.
How much?
Yes, sir.
Tell Dr. Mamarian to claim kingdom, he has to be here.
I made them aware yesterday that I'm going to use his photo, so it was a verbal permission.
If he's not here, use a better photo. It's more compromising.
So our next case is a young lady who in 2009 had a biprosthetic aortic valve replacement with a Mosaic 23 millimeter valve that when presented, she was complaining about a month or so of fevers, chills, constitutional symptoms basically. Eventually was found to be bacteremic, and on her echocardiogram found to have moderate to severe aortic valve regurgitation with vegetation on the biprosthetic aortic valve. She underwent replacement of the biprosthetic aortic valve with a St. Jude 23 millimeter valve, and postoperatively did reasonably well, did physical therapy well, no major problems, a couple episodes of AFib, RVR, and she was getting a post-op echocardiogram was approximately 4 days after the procedure. So this is the initial echocardiogram post-operative. Somebody want to describe what they see? Wash. Do you know?
Did I know the case already? Cheating.
Okay.
Do you?
Yeah, because I helped her take
Yeah,
pictures.
she did. She took pictures.
It's staring at me in the face, so I know what it is. But it's part of business.
What, the mitral valve?
The angle.
Bashar?
Yes, sure. So very small mother anterior pericardial effusion. Ear doesn't look normal to me, and I think there's some wall motion abnormality. The septum is paradoxical, but ear goes down. I see the prosthetic valve. I don't see the leaflet clearly. The mitral. Just waiting for.
Okay, so we'll revolve around that loculated pericardial effusion, if you may. This is the contrast image.
Oh, nice.
Sorry. Is it? So this is a contrast image showing that area where that loculated pericardial effusion was.
Funky.
Now what do you think?
Maybe, I mean, there was a direct communication. You would see the contrast in the pericardium, so it's not direct communication. I'm thinking maybe it's pseudoaneurysm.
No.
Where's the contrast, though?
Yeah, it's weird.
But why
that
is
there's
there
no
a
contrast.
contrast?
Yeah.
There's
Color
no
with no
echo contrast in there.
That's not what contrast is.
What's the procedure done, like transapical or anything like that?
Nope. So there, went over the operative report there, on the first one and the second one, and there's no, nothing close to the apex. So this is actually the CT
nice.
scan showing you the actual track. So on the operative report, they obviously took them back for repair, but on the operative report, the area around that track was ischemic and was scar tissue. There was a coronary angiogram that was done two weeks later after that. The coronary angiogram was clean. So the hypothesis was an embolic event through the LAD, peri-operative, that caused this ischemic scar tissue and subsequent perforation.
That's a beautiful picture. I'm still baffled by
No contrast
that
in the.
there was no contrast. I guess
Is there a near-field artifact?
it's
or
probably
near-field?
very.
Yeah, multiple images actually don't, I mean, there's
Go back,
multiple images.
go back
of
to
this.
the other one. Go back.
First one.
Yeah.
It's a beautiful contrast there.
Yeah, I mean, the contrast is well,
Here you'd almost think that it was filled with thrombus, but there is no thrombus
No, I mean,
in
there's
the
a
CT.
place for, no, there's place for velocity to be there.
Mhm.
You really can't explain it.
Could you see a filling defect on the angiogram part on the CT?
No, just full of contrast.
Unless you think it's bubble
Yeah, there's like contrast
in the near field. Maybe they saw the
I
bubbles.
mean, isn't
and
that pretty
we
quick
destroyed
to
it.
develop a, I mean, that,
That's so bizarre.
this is one week after.
1 week?
The CT scan was 1 week
So it's
after?
within range.
Were they on
Mechanical complication
anticoagulation?
of infarct.
Did you?
No.
Did you put a CW through this?
Through it,
Yeah.
yes, there was.
How high was the velocity?
Aliasing was high.
No, mostly to see, I mean, we're talking about, well, how much is the amount, I mean, yes, you see high velocity, but it's how much flow is actually occurring. If the flow is very tiny, you're not gonna have as much contrast going in because it's dilutional, right? Another one is if the velocity is high, I mean, you'd think it'd be, I don't know how high it would be because it's ventricular pressure against whatever pressure is in that sac. Then you can have some shearing of the bubbles and destruction of the bubbles. And third is you're in the near field, conceivably you're destroying more. However, against that is, my goodness, I mean, this is among the most gorgeous contrasts you can get without, right? Without any destruction, there's no, you know, there's, you know the mechanical index is not high, right? It is it's a problem, and the reason why it's a problem is that this is a documented pseudoaneurysm and has no contrast in it. So you can't use contrast to exclude it.
Or there is contrast with the.
Well, yeah.
No, I understand that, but.
Yeah, but on our echo, no. And then, this is another part of the same study.
So are you calling that a pseudoaneurysm or contained rupture?
Pseudoaneurysm. It was called pseudoaneurysm, and it was.
But what's the difference? There's no difference.
That's about the same.
That's the same.
And does it definitely come off the LV on the CT? Because it's very close to the RV
No,
apex
it
too.
comes
The
down the
RV
LV.
would be under way less pressure than the LV. But they definitely thought that it came off the
Came in the
LV on the
LV,
CT.
Ahmed, was there contrast on that initial echo, or did somebody go back and put contrast
There was contrast with the initial echo.
on the initial one?
Yeah. And then she coincidentally also had a membranous VSD. That was not obviously in the first echocardiogram that was done with the initial valve.
So it's acquired VSD,
Yep.
surgically related.
So I think one of the questions I thought about this, because I mean, this is not a brand new case, it's been a few months, but was that in a situation like this, post-operatively, would somebody put a Doppler on this, or just call it a loculated pericardal effusion and walk away? And just monitor and so forth, but if somebody did place a Doppler on it, you would see that, you know, if you're doing this post-operatively, you would probably call it just loculated pericardal effusion and then let it be. Because you put Doppler on it, you were able to see the.
The suspicion for the
further
Doppler
investigation.
should be high because the myocardium is not normal. Right, if it's akinetic and there's a bulge, you gotta look. If it was contracting well,
But it's akinetic right after surgery, right after, a few days after surgery.
but it's an
No,
AVR,
akinetic.
you're not supposed to have an akinetic
No,
apex after
akinetic,
AVR.
yeah.
So the point is, if you see a loculated effusion with completely normal myocardium at the apex, it's less likely to be a mechanical complication. So some of it is the company that it keeps. If you see this mass, in addition to regional hypokinesis, that should send the flags up.
Cool. That's it.
Great case.
Yeah, that's a great case.